السلام عليكم ورحمة الله وبركاته. I'm Najla Abdelaziz, consultant neonatologist from King Faisal Specialist Hospital and Research Center in Medina. It's my pleasure to moderate this educational activity. Thank you for joining us tonight to discuss neonatal seizure. And I would like to thank Dr. Adnan Hadid for arranging this activity. First of all, may I briefly introduce our speaker, Dr. Daniah M Kurdi. She is an assistant professor at King Saud University in Riyadh and a consultant pediatric neurologist and epileptologist. In 2012, she graduated from University of the Sciences in Philadelphia with a master's degree in public health. Her pediatric neurology residency started in Saudi Arabia, followed by residency in pediatric neurology program in Canada. As soon as she completed her residency, she started her epilepsy fellowship at the Children's Hospital of London, Ontario in Canada. She just came back last year. Her professional membership include the Saudi Pediatric Neurology Society, the American Epilepsy Society, the Canadian Association of Child Neurology, the American Academy of Neurology, and the Center for Brain and Mental Health in Canada. Dr. Daniah, you may begin your presentation now. And dear audience, to ask questions, kindly type them in the chat section.
السلام عليكم ورحمة الله وبركاته. مساء الخير عليكم جميعا. First of all, thank you, Dr. Adnan, for inviting me. And thank you for organizing this event. It's a big topic and it's in the evening, so I hope I'll keep you entertained for the next hour or so. So let's start with, I chose the topic of neonatal seizure. Where do we stand? To highlight some differences among centers that I faced since my return to Saudi Arabia. So let's start. Okay, so my objectives of this talk is to highlight the ILAE, which is the International League Against Epilepsy classification for neonatal seizures and epilepsy, to understand the unique neurophysiology of the developing brain, to highlight the role of the ambulatory integrated EEG and CEEG, which is a continuous EEG, to discuss treatment options for neonatal seizures, including the choice of anti-seizure medication and duration of treatment. So, as always, we start by a case introduction. It's a common case to all neonatologists, I believe. This is a 2-hour-old baby who was admitted in the NICU after being delivered by emergency C-section due to placental abruption at full term. Apgars were 2 to 3 at 1 and 5 minutes. Resuscitation was done properly at the delivery room, and then the baby was placed on mechanical ventilation. At 6 hours of life, the following movement was observed by the bedside nurse. These are all YouTube videos. There is no copyright, and then I'll tell you later in my discussion, you can Google it and you can find it, okay? Okay, so you can see this movement, and I don't know if the functionality of raising hand or if all the question that I want to ask is, do you think this is a seizure or not a seizure? Do we have the functionality of raising hands or something, or no? Dr. Najla? Or Dr. Adnan?
You can make a move.
Yes,
I'll try
we
to
have,
do it. Just
we have
second, please. Yeah.
Dr. Noura? Yes, Dr. Noura.
So it just, okay, so just to make it, just raise hands if you think this is a seizure, and don't raise hand if you don't think this is a seizure.
Until now, we have 14, 15, 16. Okay, numbers increasing.
Okay. Okay, so most of the people, they think, okay, oh, wow, we have the pull here. Okay, so almost 76%, 78% they think that this is a seizure. I will come to this, remember this video because I will come to it later. So 1 second, let's go to the next. Okay. So neonatal seizure, this was indeed a seizure. So neonatal seizures is relatively common neonatal presentation. It occurred in 1 to 3 in 1,000 live births. Majority of seizures in the neonatal period are provoked due to acute illness or a brain insult. Previously in the literature, they used to call it acute symptomatic seizure. However, based on the new International League Against Epilepsy classification, the proper terminology is acute provoked. So do neonates have seizures or do neonates have epilepsy? So most of the time, neonates have seizures rather than epilepsy. And why is that? Because epilepsy has a clear criteria for diagnosis. That includes having 2 unprovoked seizures at least 24 hours apart, 1 unprovoked seizure, and other evidence that the recurrence of seizure is high, up to 60%. This is based on EEG or MRI finding. And usually for the criteria A and B, we are dealing with an outpatient setting and different age group. And criteria C is basically a diagnosing epilepsy syndrome, which is the most likely in neonate. So as you can see, these 2 probably do not apply in neonate. And then, so we are left with just a diagnosis of an epilepsy syndrome in order to call neonate that neonate have neonatal epilepsy rather than seizures. So 90% seizures, only 10% epilepsy syndrome. And there is one interesting fact that in neonate, most of the time, seizure is not a clinical diagnosis. In any age group, we would say epilepsy is a clinical diagnosis. Most of the neurologist specialists or epilepsy specialists would agree if they see the video or something of an event that this is a seizure. However, this is not true in neonate. And we know that based on this very popular article that was published in 2009. It was done in Ireland, and it measured the inter-observer agreement in neonatal seizure identification. So what they did in that study is that they have 20 video clips, 11 seizures and 9 non-seizure. When I say 11 seizures, it means confirmed with electrographic correlate with the conventional EEG. And then 9 were not seizures. These videos were evaluated by 91 doctors that include neonatologists, pediatric neurologists as well, and 46 other health professionals, bedside nurses, and RT. What they found is that the correct identification of events was 10 out of 20. So basically a flip of a coin. And what was interesting is that among doctors, so when they measured the kappa is the measure of agreement, okay? If you have 1, then you have a best agreement. If you have less than that, it's less agreement. So among doctors, they agree only 0.2% compared to the other health professional. So they saw the video, they all agreed, seizure or not seizure. But did they agree on the correct diagnosis that this is a seizure or not a seizure? It's almost, there was no agreement, 0.09 among doctors and minus in the non-doctors group. So the challenge, it is well known, the challenge in this age group, in neonate, okay? So when the International League Against Epilepsy published their classification of seizure, the publication was done in 2017, and then the special task force for neonatal seizures, the task force made their classification of seizures in 2021, and you can see some important difference. In neonate, for any seizure, it is almost always focal seizure, while in any other age group, seizure can be variable, can be focal, can be generalized, or even unknown onset. And then basically in any other age group, we are talking about the clinical onset seizures. In neonate, we have either electroclinical seizures or it's only electrographic seizures. And after that, we diagnose an epilepsy syndrome. There is one big difference here in this table that we prefer the term of electrographic rather than subclinical seizure. And why is that? Because neonates, sometimes they have subtle movement that we cannot identify. Either this is behavioral arrest, this is some mouth automatism, they are chewing in the tube, they have only tachycardia. So the clinical feature might not be obvious. So that's why rather than telling that it is for sure subclinical seizure, we prefer to use the term electrographic seizure only. And there is also one unique thing when we talk about neonate, and this is also true in the critically ill child in the ICU, in the PICU, that when we start medication on neonate, and the clinical event subsided, the clinical seizure subsided, and we think that we treated the seizure. But in fact, what we are doing is something called uncoupling. Uncoupling meaning that we treated the clinical manifestation, but actually the seizure continued electrographically. That's why the importance of EEG correlation with treatment of continuous EEG. You might suppress the clinical features of the EEG, the clinical feature of the seizure, but the EEG might continue as electrographic. So this phenomena is called the uncoupling. Okay, and it is unique also and more common in neonate because of their development and maturation. And I will talk about that maybe in the neurophysiology of the neonatal brain. So what do we do when we connect the patients to conventional EEG? This is our 1020 standard EEG electrode placement. When the baby's head size is smaller than 35 centimeters, unfortunately, we cannot put the full channels. So we do the neonatal montage, which is a restricted montage from the electrodes. And for the ambulatory integrated EEG, it's variable. The standard is C3, C4. The recommended by the American Clinical Neurophysiology is to have also P3, P4. I know not many centers does that, so it's mainly C3, C4. This is a small clip to show you how the raw EEG look like and how the seizure look like on the EEG. So we are comparing two channels to two channels, left hemisphere to the right hemisphere. The odd number is left and the even number is right. And what we can see here that there is electrographic buildup of a spike discharges, rhythmic all over the C4, so the right central head region, okay? And then let me play this. And then the seizure evolved. It looked like as if it is generalized, but it actually remained to be focal. So what if we don't have a conventional continuous EEG? All what we have is just our clinical judgment. So this was recognized by the Brighton collaboration of Neonatal Seizure Working Group, and they published their recommendation in 2019. So, okay. So basically, if you have a baby who's at risk of having seizures, or you have a baby with a clinical event, okay, and you have the EEG available, perfect. You have your gold standard. Gold standard investigation confirm that this is an EEG and you treat accordingly. You capture the event and you have the EEG, but there was no any correlated electrographic seizure. This is exclusionary. You can be confident to exclude seizures. So this is level 5, meaning that you can totally exclude it. If you don't have continuous EEG, you don't have your gold standard, but you have ambulatory integrated EEG, then this is level 2A. This is a probable diagnosis of seizures. But if there is no ambulatory EEG correlate, it is insufficient evidence to exclude that this is a seizure. And why is that? This is, if you remember, you are only have two channels, only at the central head region. That clinical event might be a seizure originating somewhere else, okay? If you have no electrographic thing, not CEG, not CEEG or ambulatory EEG, but you have a skilled personnel, skilled neonatologist who is comfortable with seizures, the most frequent seizures that are easily identified clinically are the focal clonic or focal tonic seizure. So this is a probable diagnosis of seizures. If you have any other seizure type, this is the least type of evidence that you have. It is possible, possible not, you cannot exclude. And basically you have insufficient evidence to say yes or no. So how do we classify? I just mentioned briefly the focal, clonic, or tonic. How do we classify seizures in general? So again, neonate is unique. So this is the usual classification for any other seizure, for any other age group above neonatal period. Focal, generalized, or all of that. However, in neonate, this doesn't apply. And there is nothing called focal aware or impaired aware seizure in neonate. And one interesting part, and also unique to neonate, that we classify seizures not based on the first clinical manifestation, but the most prominent seizure type. For example, they start with bicycling movement, and then they have tonic stiffness, and the tonic stiffness persists the whole time. Then you would call that as a tonic seizure. So the motor manifestation of the seizures, neonate will never have atonic seizures. They don't have hyperkinetic seizures. They don't have emotional. They don't have sensory seizures, okay? And the seizures in neonate, they don't go focal to bilateral tonic-clonic seizure. So this is the short frame, unique neonatal seizure classification. So you have electroclinical or electrographic. F, electroclinical, the motor will be automatism, which is, I'll talk about it in details, either oral or motor, clonic, epileptic spasm, myoclonic or tonic, autonomic or behavioral arrest, and then it's the sequential seizure. There are other, yeah, I said that. Okay, so this is the detailed description of each type of the seizures. Automatism, it's either oral automatism, or it is the motor automatism of the hands or legs. Clonic, it is probably the easiest. It is rhythmic jerking of one extremity, either the arm or the leg. Epileptic spasm, it is very hard to differentiate clinically from the myoclonic jerk, because they are all shock-like quick seizures. And the way we differentiate between them is mostly by the continuous EEG and the duration. Tonic seizure is also easy to identify. It is just the stiffness of either one limb or all limbs, or like arms, legs. And then you have the autonomic seizures that classically either it is apnea, it is tachycardia, or like any vasomotor changes, and then the behavioral arrest. And as you can see, this one, you cannot make that clinically. You have to have an EEG correlation. Two types of unique seizure type, and this is probably neonate and also early infancy, the sequential seizures. It means that the seizure will start at, let's say, clonic, and then it will stop immediately. It will switch to other seizure type, could be tonic. So this is what we call a sequential seizure. And then we have the migrating focal seizure of infancy, which means that within the same seizure, the seizure is migrating in terms of location. For example, it started on the left arm, and then now it went to the right arm or to the left leg, etc. Or it is migrating also into the EEG. When we are on the continuous EEG, we see the ictal pattern changing from one hemisphere to the other, or from one location to the other. So can we make a distinction between seizure and where does the seizure localize to? because as epilepsy specialists, this is our main aim when we look at the seizure to understand where is this seizure originating from. Because they are neonate, they are unique. We cannot make, most of the time, it is hard, especially if the seizure look like it is generalized. Why is that? Because the myelination of the brain of the neonate, it follows certain pattern. Usually, it is caudal, rostral. It starts inferior and goes superior. So the maturation of the neurons of the network in the brainstem maturate way earlier than the cortex. So that's why when the neonate had seizures, it is a release phenomena from the brainstem rather than cortical originated seizure. So that's why we cannot determine, is it coming from the right hemisphere, left hemisphere, or where? But there is something we can do, and this is based on extensive research by the Neonatal Registry Group. Can we look at the seizure and based on the most common seizure type, understand what could be the likely etiology? What is the cause for the seizure? And this was a study that was published again by Hannah Glass and colleagues, the Neonatal Registry, Seizure Registry Group in the USA. And they published that in May 2021. So basically what they did, it was a prospective cohort, multi-center study. They had a total of 60 patients, 20 with epilepsy and 4 with acute provoked seizure. The aim was to classify the seizure, whether they are clonic, tonic, myoclonic, or electrographic only, and determine the etiology. What they found, for example, in HIE, usually the most common seizure type is the orange, which is the electrographic only seizures, or it's the clonic seizures. Yes, they might have myoclonic seizure as well, okay? And this again highlight the importance of EEG in HIE babies. Clonic seizure tend to correlate probably more with structural, especially stroke. They have clonic seizures, and they might also have electrographic only seizures. Once you have a tonic seizures, especially if it is refractory to treatment, you have to think about a channelopathy. And by channelopathy, we mean the new advances in genetic testing and genetic recognition of potassium channelopathy, sodium channelopathy, and we will come to that later. And then myoclonic seizures tend to be more involved with metabolic. And in that cohort of patients, they had some specific lethal mutation called the BRAT1 mutation. From that study, they were able actually to give us a detailed electroclinical correlation about each seizure type. For example, we know that with the clonic seizures, the EEG onset will be first. With tonic seizure, they tend to occur together. And then they were able to give us, maybe I'll show you in the next slide, the nice summary of the EEG, how the difference, when to suspect that this is acute provoked seizure versus a neonatal onset epilepsy. I know most of you is familiar with the ambulatory integrated EEG. And so you can see from here, for example, that there is a clear variability in the background with the sleep-awake cycle. And then suddenly there is this sudden jump of the background above, way above, higher than 5. Okay, so if you take only a snapshot of this one and compare it to the raw EEG tracing, it perfectly correlates with a seizure. What's interesting with the provoked seizure, that after the seizure finished, the post-ictal phase, the background goes immediately back to normal. If you compare that to here, you can see that after the seizure happened, there is a suppression of the background, and then it goes back, maybe probably other seizure also. And if you can see here, there is a clear correlation with the raw EEG, and you can see the suppression continue. So they were able to give us this nice table of comparison between each common provoke etiology of the seizures and what is the common finding on EEG. So after this like didactic talk about neonatal seizures, let's practice some videos. So let's go back to the first patient that we all agree that they were seizures, and I don't plan to trick you. They will all be seizures, okay? So if you want to classify this seizure based on the seizure type in terms of myoclonic, tonic, clonic, autonomic, or automatism, what would that be? Najla or Dr. Adnan, if you want me to replay the video or you think it was clear, let me know.
Still no answer. I'm waiting.
ممكن نعطيهم خيارات دكتورة.
طيب الخيارات حتكون tonic, myoclonic, clonic, autonomic or automatism.
راح أعطيهم أنا الخيارات فقط 1 2 3 4.
Okay.
أنا ما راح لحق اكتبهم.
Okay.
4 ثواني. Save and launch.
هي 1 2 3 based on ما نعرف الكود حقها. 1 is
لا حسب الترتيب اللي ذكرتيهم حضرتك.
اوكي
هنا يتذكروا التايب.
Okay, تمام. Then I'm assuming 4 is, I don't know if it is autonomic or automatism. Fine. Okay, perfect. What I like is this variability. Okay, most of you agree on 4. Maybe it was automatism. Okay, so let's stop this one. 4. So this one is a class. So I know most of you like the paddling or bicycling movement. So this is automatism. This is a motor automatism. So let's go to the next video. Okay, so I'll maybe close this one. Okay, so would this seizure be tonic, clonic, myoclonic, or autonomic? Okay, nobody is with autonomic, which is great. Okay, good. Okay. So this is a classic clonic seizure. If you see a neonate with this one, the first thing as epileptologist I would think about is probably stroke or intracerebral hemorrhage on the contralateral side. Okay, next, let me see. Okay, this one. So what do you think this is? Tonic, clonic, epileptic spasm, or myoclonic? Okay. Perfect. Okay, so 78% agree that this is a tonic seizure. And you can see why I say that to understand the localization sometimes is hard, because this is tonic stiffness of both extremity. I know it is focal, but I can't say from which hemisphere, which hemisphere is the reason for this seizure. Okay. Okay, so now let's talk a little bit about neonatal epilepsy. So multiple attempts, and if you review the literature, you will find like a lot of talk about how to define neonatal epilepsy. In 2017, Renee Selhas, which is a very well-known neonatal neurologist, and her group at UCLA, they tried to classify neonatal epilepsy. And they made with the 3 recommendations. One is a diagnosis of neonatal epileptic encephalopathy, previously called Otohara or the early infantile myoclonic epilepsy. Neonatal epilepsy related to known brain malformation confirmed with a brain MRI, or benign familial neonatal epilepsy. And what they found in their registry, that the acute symptomatic seizure was actually 87% in the neonate. The brain malformation was only 5%. The other epileptic encephalopathy was only 8%. Then the ILAE task force, they came with their classification, a new classification of all epilepsy syndrome across lifespan, from neonate to infant to children to adults. And because it is neonate, so I'll only show you the neonate. So now we don't use the term of benign, and especially in neonate, because once we diagnose self-limited neonatal epilepsy, it is always a retrospect diagnosis. Once the neonate is confirmed to have a seizure, we treat. We don't even put in our mind that this is a self-limited epilepsy. Of course, unless there is a family history, blah, blah, blah. But again, we made this diagnosis in retrospect. So there is self-limited neonatal epilepsy, and there is that big category of the developmental and epileptic encephalopathy. And you can see that early infantile developmental and epileptic encephalopathy, epileptic encephalopathy is now the replacement for Otohara and early myoclonic epilepsy of infancy, because of the evolving genetic field and that the distinction between them becoming hard. And then once you have specific genetic mutation, you name it based on the etiology, whether it is the potassium channelopathy or the pyridoxine dependent or pyridoxal or whatever, even if you have a structural lesion. So I already told you about that. We know that from the early infantile developmental and epileptic encephalopathy that it is usually drug resistant. And we know the birth suppression pattern, which is a non-specific but severe in the EIEE. The neuroimaging, metabolic, everything usually comes, the neuroimaging very unlikely to be positive. So that's why we rely a lot on genetic testing. Predominant seizure type is variable, tonic, generalized tonic, myoclonic, and just remember that tonic is our key to think about probably that it is epilepsy. Myoclonic, focal, or epileptic spasm, also sequential seizure might occur. And now, as just a brief to tell you that whenever you have a confirmed genetic testing, you name the diagnosis based on the genetic testing. These terminology, I hope it is not used anymore. And the reason is that there is, yes, they are mixed probably together. There is no clear distinction. And at the same time, making the distinction will not change anything in how we treat these babies. Okay, so unique neurophysiology of the developing brain. We know that it is a developing brain. So everything is related to the maturation of the brain cells and the underlying even channels. So one of the most inhibitory channels is the GABA. And interestingly, in neonate, the type of the GABA receptor expressed in neonate, it's different than infant and children. So GABA in the adult, the usual adult or children, it is called the KCC2 receptor. And what happened when, for example, when the GABA is released or because of phenobarb enhancement of the GABA activity, the chloride will go inside the cell. Once the chloride goes inside the cells, it causes something called like hyperpolarization. Hyperpolarization meaning like trying to stop the seizure or this action potential. While in neonate, because they have different type of receptor, just because of the delayed in maturation. So they will have the NKCC1 receptor. What does this mean? That this receptor actually doing reverse action of the mature GABA. Rather than being excitatory, it's being inhibitory. You might say, okay, so how come the phenobarb is still working? Remember when I said that the maturation goes caudal, rostral. So you might be able clinically to see no seizures, but you never know electrographically what happened, because these neurons that are still in the cortex might be still excited. Other thing, so some other unique features of the neonatal brain is that the expression of the NMDA receptors. NMDA receptors are excitatory receptors but for the glutamate, which is an excitatory neurotransmitter. So the maturation of these receptors peak within the first week, followed by the AMPA receptors in 10 days. In order for GABA, especially GABA B, to be mature enough, it will need at least 3 weeks for maturation. And then the other GABA B is probably produce a paradoxical, this is the GABA A, and the GABA B, which is the other receptor, that is the one that peak after 3 weeks. The GABA A initially provide the paradoxical effect, and then it becomes the usual adult type KCC2 receptor. In addition, all these neurons are supported by astrocyte. The astrocyte maintains the electrical potential among the neuronal cells. If you have immature astrocyte, it means the propagation of the action potential just becomes faster. So an increase in the gap, increased number of the gap junction, it means that once the action potential or this excitatory action potential is there, it will propagate and spread easily. This is one example that I told you about how the glutamate receptor is also different because of the immaturity of the brain compared to the mature glutamate cells. So once you have the glutamate, the excitatory neurotransmitter to the cell, it will cause the sodium influx to the cell and promote excitability. In order to stop that, you have a safety block, which is the magnesium. Once the magnesium is attached to the glutamate receptor, it will block the sodium influx. And at the same time, you have the N2A subunit, which is the mature subunit of the receptor. What happened in neonate is actually that they have N2B subunit, and which make the magnesium block harder. So in summary of all of what I said, you have an excitatory receptors that mature way much earlier than the inhibitory system. And you have even the excitatory is more excitatory than the usual mature type transmitter. So by understanding all these in neurophysiology, how do we treat neonatal seizures? So based on what we said, based on the Brighton collaboration, if you have a definite seizure, level 1, you have an EEG correlate, you treat. By treat, we mean treat immediately within 1 hour, okay? And I'll talk to that in the next slide. If you have a probable seizure, meaning that either you have an ambulatory integrated EEG or it was a clonic or tonic seizure, then please treat. If you are in doubt, this is a possible seizure. It might be automatism. I'm not sure. It might be apnea. It could be autonomic. If there is a gray area, consider treatment, but not strong evidence. If it is suspected and you don't know what you are doing, please do not treat. So as you can see from this table, that was actually only, this is based on the Brighton collaboration, but it was simplified by a new review that was published in the New England Journal of Medicine just recently, probably last month. Should we treat every seizure? Okay, there is multiple answers to this question. First of all, the general rule, time is brain. Once you confirm seizure, treat within the first hour. And there was many studies that trying to correlate the poor neurodevelopmental outcome with delayed treatment for neonatal seizure. So there is no question that you treat immediately. So you treated the first seizure. Once you have it, you have a seizure that lasted at least 30 to 60 seconds, you start treatment, okay? How do you escalate therapy then? The seizure stopped. When should you start escalating treatment or decide what to do next? Usually what will determine that is the seizure burden, okay? Not seizure frequency, which means that to determine the seizure burden, you need to have a certain amount of seizure, either by duration or number in a certain amount of time. For example, what is agreed upon is 30 to 60 seconds in an hour, or like 10%. For example, you have 1 hour, the baby was seizing during this hour for roughly 1 minute. 1 minute is 10% of the 1 hour, so you should treat and escalate therapy. Why is that? Why are we very precise in terms of seconds and all of that? Because in HIE baby, for example, we know that they will have electrographic seizure. The question is, should I chase every electrographic seizure? He had 10 seconds, he had 15 seconds, only 20 seconds, but 2 hours, no seizure. Should I escalate midazolam, for example? The answer is no. If the seizure burden is low, don't escalate. Okay, you might think that this is, oh, how can I calculate this? How can I use the seizure burden, like in a bedside manner? Actually, we live in a very good time of advanced technology, and I hope one day we will have this even in my center and also on Saudi, hopefully. So there is, we can do 2 things actually. I can have the machine for the continuous EEG, which has the capability of showing the other screen of the trends only. The trends will allow you to know the seizure burden quickly, easily, and identify it. For example, and what is the best about combining the 2, the conventional EEG and using the other software to show the trends, or what we call it quantitative EEG, is that I can show you the channels that you are familiar with ambulatory EEG, and identify the seizure. Once you identify and you see this elevation from the baseline and you think that this is a seizure, you can immediately look back to the raw tracing and confirm that this was a seizure or no. Even if you, for example, there is no manpower, there is no neurophysiologist or epileptologist overnight to look at the raw EEG tracing, at least you would have established the pattern of the seizure, and you have the bare minimum, which is the ambulatory integrated EEG, to confirm. And here you can play around with the time. You want to display over 8 hours, over 1 hour, over 2 hours, and determine your seizure burden and determine response to treatment, clinically and electrographically as well. So this is from a book that is called Atlas of Pediatric and Neonatal ICU Setting. Okay, neonatal seizure pathway. There is no doubt that a standardization in neonatal seizure pathway improve effectiveness of treatment. And why is that? We already know that there is inter-physician variability in terms of the way of treating neonatal seizures, and even the comfortable level of escalating therapy for neonatal seizures. So if we leave everything without protocols, without pathway, without guideline, we are left with a treatment that is based on a personal preference, based on local experience, based on center only, for example, experience, not a standardized, like standard of care treatment. So this study was done in 2020. It was a multi-center only involving the level 4 NICU in the United States, including CHOP, I mean the Children's Hospital of Philadelphia and Boston Children's Hospital in Cincinnati, all of that. biggest neonatal centers in the US, and they compare the variability. They have their own pathway, but they collected all their pathway and they present the variability in the neonatal seizure treatment pathway. So there is all of them for sure, they all have access to continuous EEG. And they all started with the first line anti-seizure medication as phenobarb, okay, within probably the first 30 minutes to 1 hour, okay? And then after that, to escalate therapy, this is where the variability, whether you will check the seizure burden within 30 minutes or 1 hour, whether you will treat any additional seizures, but at least they all agree that you have to give it a time to assess the seizure burden. And then you will start your second line treatment, okay? And then the second line treatment, 5 center were using phosphine, 2 center were using levetiracetam after, okay? Once you reach the third anti-seizure medication, it is usually most of the center will be comfortable with starting midazolam infusion. If you reach a third line and there is no clear etiology by that time, and you are suspecting probably this could be pyridoxine or pyridoxal phosphate, at that time you could start, and that will help you to determine the response to treatment if you have the continuous EEG. Because yes, theoretically they say that the response can take 24 hours, but realistically in all published cases, confirmed with continuous EEG for pyridoxine or pyridoxal 5-phosphate dependent epilepsy, the response is within 1 hour with clearance of the EEG from the ongoing seizures. When to discontinue? So EEG discontinuation, if there is a 24-hour seizure-free midazolam is weaned, discontinue the continuous EEG. When to discontinue anti-seizure medication, we will probably talk about it a little bit later. I'm just looking at the time, I think it's okay. Okay, so there is variability. Some of the center will wean after 2 days of seizure freedom. That was probably 1 center. Other center will reassess at least 24 to 40 to 72 hours before discontinuing the anti-seizure medication. The other will consider the discontinuation prior to discharge, or they will leave it at maximum of 4 weeks after discharge. Okay, a big question. Do we have a preterm seizure pathway for seizures in a preterm? The quick answer will be no, it is very variable. And if you search the literature, most of the guideline, most of the inclusion criteria for any neonate is neonatal 36-week or above, because you are dealing with a very immature brain, you are dealing with very excitable brain. The response to treatment, if the preterm baby start seizing, is unfavorable, unfortunately. But to answer this question, I don't really have an answer, because this is a case-based, case reports, self-experience with treating this category of neonate. Can we have some novel treatment, and based on our understanding of the neurophysiology, can we design a specific treatment for neonatal seizure? This was attempted, and the only reason, because this is a big trial and you might heard of it in your training or in your career, the NEMO trial, which was done for the bometanide for the treatment of seizures in newborn with HIE. It was an open label dose finding feasibility study. And what they did is that because the bometanide, it is a loop diuretic, but it works specifically on the premature, the chloride channel. That is similar to the channel that is in the loop of Henle in the kidney, okay? So they think, okay, maybe this diuretic can work specifically, and it has good blood-brain permeability. It might be effective in treating neonatal seizures in HIE baby. The study was stopped prematurely because of concern about predominantly deafness although it was there is a question whether it was actually within the same group who was also treated with aminoglycoside, whether that was a double hit or it was a severe HIE already. But anyway, there was a big concern about safety, and the trial was stopped. I know that they finished enrollment for one other study. I don't know, I didn't see any published result yet. The big question is, how do neonatal seizures respond to treatment? This again was a study was done on the by the neonatal seizure registry group. This is based on the most commonly used medication. So there is almost no doubt, and there is universal consensus that the first medication that is used in neonate is the phenobarb. So this study was a prospective multi-center study involving a total number of 534 neonates who are treated with acute symptomatic seizure. And maybe you can realize that they were still using the old terminology. The response, whether they had complete response or incomplete response. And you can see that 508 neonates were treated with phenobarb, and the response was not that great. There is incomplete response. With fosphenytoin, it's almost always incomplete response. With levetiracetam, the incomplete response is also high. From that study, what is interesting that to know the risk factors to predict neonate that will not respond well to treatment. And that especially if you have a neonate with intracerebral hemorrhage, more than a neonate with HIE or a stroke. Stroke, they might have a rough start, but it tends to respond to anti-seizure medication. The ex-preterm babies, especially to less than 28 weeks, if the seizure burden is high, especially if the baby is in a status epilepticus, HIE, if they did not receive hypothermia, if there is an abnormal interictal EEG. And unfortunately, the incomplete response is expected. So always we face this question, when to stop the anti-seizure medication in neonate. And actually there was an NIH-funded study to have a randomized control study as the best evidence to answer this question. Unfortunately, it failed enrollment. Why? Because of hesitation among neonatologists and probably even like the pediatric neurologists to randomize patients whether to stop or to continue, and also among parents for their newborn to whether to be randomized whether to continue in treatment or to discontinue treatment. So that's why the neonatal registry group published their prospective trial. So it is not double-blind or not randomized, but this is the best evidence that we could have for now. It was published in 2021 about the safety of early discontinuation of anti-seizure medication. They had 35 enrolled. At the end, they had 228 analyzed patients, and the primary outcome from that study was the neurodevelopmental outcome for the newborn who stopped anti-seizure medication before discharge or who continued on anti-seizure medication. They used easy used scale because it needs only telephone communication with the family to go details about the development and assess. So it is called the Warner Initial Development Evaluation of Adaptive and Functional Scale. Okay, so WIDA FS for short. And also as a secondary outcome, they were looking at the onset of post-neonatal epilepsy. So the median age to develop epilepsy after neonatal period was around the age of 7 months, and with interquartile ratio 3 to 14. And what they found is that actually patients who maintained on anti-seizure medication had higher incidence or higher prevalence of epilepsy. And this probably, so the message from that is that even if the patient remain on anti-seizure medication, it doesn't work as a prophylaxis. They will develop seizure anyway, okay? At the same time, their neurodevelopmental outcome for the patient who stopped the medication early were not inferior, it was not worse compared to the neonate who continued on anti-seizure medication. For that reason, the conclusion is that it is safe to discontinue anti-seizure medication for acute provoked seizure before discharge. There is a lot of recent publication also from various groups, whether the Italian or also now the Canadian group. They published their recommendation. They call it the Newborn Brain Society, and they agreed on the early discontinuation. They have some specification in terms of do EEG after actually you discontinue the anti-seizure medication, just to determine as baseline and the risk of developing epilepsy. Okay, so some few words about, because we are almost reaching 1 hour. Precision medicine in a channelopathy. Channelopathy, by that I mean the early epilepsy syndrome in neonate. And without going into detail, we have either established precision therapy, that like genetically targeted treatment. We have potential based on a small non-randomized trial, and we have hypothetical medications that could work. Where are we now, right now, in terms of targeted therapy for neonatal epilepsy? We are probably still in the suggested potential therapy. There is not, especially when we talk about sodium channelopathy, I know we always talk about using phenytoin or carbamazepine for sodium channelopathy. Yes, it can be effective, but what we are talking about is cure. So yes, they might respond well, but not a total resolution of seizures. Okay, so this is all potential therapy. Some take-home messages from all of this talk is that neonate, they have seizures 90% more than epilepsy. Seizures in neonate are focal, either electroclinical or electrographic. Less evidence exists for clinical judgment. Tonic seizure is a common semiology for channelopathy rather than acute provoked seizure. Early initiation of anti-seizure medication reduce the seizure burden and improve outcome. Neonatal seizure pathway improves the quality of care, no doubt. It is safe to discontinue anti-seizure medication upon discharge for acute provoked seizure. Personalized medicine for monogenic epilepsy is the current and future goals. With that, I would say thank you.
Thank you so much, Dr. Daniah, for your presentation. It was very informative. And if anyone has any questions, I'm sure Dr. Daniah would be pleased to answer them. And I would like to highlight a few points here, Dr. Daniah. First one regarding the diagnosis. The continuous EEG is the gold standard for sure. But the problem with neonatal EEG, it's difficult to interpret. And EEG reports for our patient are unique, and reading them can be challenging. I have seen a few patients, alhamdulillah, few, treated for refractory seizures during cooling, and we escalated their anti-epileptic medications. And after reviewing their EEG with another neurologist with a strong neonatal EEG experience, we started weaning and discontinuing them. And I remember another patient was admitted with moderate HIE for cooling, and an EEG was mandatory after rewarming as a part of their management. And after a few days, when the patient was ready for discharge, the EEG report was released reporting severe encephalopathy. And this was why the patient was on full oral feed and clinically stable. So it's really challenging. And the pediatrician who completed the pediatric neurology residency program are accredited to read neonatal EEG. But some centers they don't have enough experience or exposure in neonatal EEG during their training. And there is a well-structured epilepsy fellowship and EEG program available for adult and pediatric patients at the same time. But the ratio for adult patients is higher, and the newborn EEG exposure is insufficient. So it's really challenging. Like, okay, in ideal situation, we have continuous EEG, but the problem is writing the report. It's really challenging, and hopefully one day we will have a pediatric epilepsy fellowship and neonatal neurology fellowship here in Saudi Arabia.
Right, just allow me to comment on that. You're probably reflecting from your experience during fellowship. So
Yes.
I'll tell you one thing. Pediatric neurologists are not qualified to read EEG unless they have a special training in EEG. And this is a special certificate, okay? So maybe in Saudi, the things are probably still gray. But for example, let's say the world standard Canada, USA, nobody is allowed to touch the EEG machine if they are not licensed, okay? The other thing, yes, neonatal EEG is unique and it needs a specific degree of a qualification and center, and it needs manpower. And that's why I said it's manpower, but also we are in the area of artificial intelligence where the EEG new software can help us a lot in terms of education. It's a long talk. It probably can take the next 30 minutes of how to improve things. But just to let you know that at least having continuous EEG is better than nothing. Training the person because I have an experience of training people just to look at the trends and be able to identify the seizures even as a bedside nurse based on the trend during night when there is no neurophysiologist looking at the raw data, okay? So we can definitely improve things and reach the standard.
Inshallah. The other point is about treatment decision. The same, it's challenging to reduce drug neurotoxicity and seizure burden while still achieving a balance between benefits and harms. Like for phenobarb, it's associated with acute induction of neuronal apoptosis. On one hand, uncontrolled seizures have an adverse effect on immature brain development. And on the other hand, the potential damage to the developing central nervous system. And there is a recent RCT compared the effect of treatment of clinical seizure versus electrographic seizure in full-term and near-term neonate. There was no difference in mortality and long-term morbidity, but there was some concern about worse cognitive function in those treated with electrographic seizures. So still, it's not clear for us if we have to treat them or not.
Okay, so let's make so few points here. A treatment of confirmed neonatal seizure. There is no doubt that we have to treat within the first hour. The best is if we have electroclinical, but if you have a strong clinical suspicion about focal tonic, these common seizure type, there is no doubt that you should treat. We talk about discontinuing medication upon discharge, meaning that this baby had HIE, cooled, warm, blah, 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 and now it is like he's after 4 weeks. Should we discontinue? There is no seizures. This is the point when we will discuss discontinuing medication. The argue is that even if I continue this phenobarb because I don't know, I'm not sure, maybe the seizure will come back, blah, blah, blah. I'm not preventing seizure, okay? If epilepsy will happen, it will happen regardless of continuing the phenobarb or no, okay? And sometimes depends on the severity of multifactorial, the severity of the EEG, the severity of HIE. Easily treated seizures, probably, and type of HIE pattern on the MRI will determine which one is most likely to develop in the future and which one is unlikely to develop epilepsy in the future. You should give the child the best option to allow neurodevelopment rather than confounding that with anti-seizure medication that probably the child doesn't need for the next 7 months at least. So why just to keep them on a high level, and usually it's 5 milligrams per kilo with good level. So why to keep them on phenobarb if they don't need it?
شكرا جزيلا دكتورة. بس في بعض الأسئلة I mean in the Q&A if we can go through it.
Okay. We have a question from Dr. Tajuddin. When to consult neurologist in case of HIE?
Only if they develop seizures.
So we don't have to keep it like a mandatory in our protocol to consult them in every case?
Okay, so the answer to this question depends if you are in low resource setting, high resource setting. High resource setting, you have a neonatal neurology group who have interest in seeing any HIE babies. In low resource setting, the baby has HIE, cool, never had a seizure, never had a concern. Probably you don't need. For example, let's say you know that your neurologist doesn't have an EEG, and you saw clinical EEG and you treated that already. So involving him later, like I don't know how much this will add. Okay, ideally, I'm a big fan of neonatal neurocritical care, where it is integrated by neonatal neurologists and neonatologists. But HIE, simple case, straightforward, you will involve neurology if the baby starts seizing.
Okay, another question by Dr. Ramadan. In case of severe HIE, do we have to stop anti-epileptic medication before discharge or just to shift them to Kibra?
Okay, good question. Severe HIE, the baby upon discharge has been seizure-free so even the precautionary group who wants to keep the baby still on anti-seizure medication, they will keep them for 2 weeks, okay? Some people would say at least 5 days seizure-free. We are not talking about refractory. Like, don't imagine that I'm talking about patient who you are escalating therapy, patient who's still having a breakthrough seizure. These patients, you will never stop. They will discharge on medication. What we are talking about, the group of patients who are ready for discharge, okay? The baby for the last 5 days improved. There are no seizures. I'm discharging home, okay? Why to keep them on anti-seizure medication? This is the question. So this population of patients who at least have been seizure-free for 5 days prior to discharge, safe to, if you are in doubt, give it 5 days, 1 week before discontinuing. What happened, unfortunately, that these kids remain on anti-seizure medication maybe until they are 2 years of age. They never had epilepsy, but they are contained on their medication since they were discharged from NICU.
Okay, another question from Dr. Tajuddin. What is the role of MRI brain for workup, management, and outcome of seizures?
Okay, ideally, yes, there is a big rule to determine the reason of the neonatal seizures, because as you know, it is most likely provoked. So, and most likely, if it is not electrolyte imbalance or metabolic, you will find your answer in the brain. So definitely you need the brain MRI. You need MRI because the degree is intracerebral hemorrhage, if it is stroke, if it is severe HIE, and even the type of HIE will make a difference, because based on the pattern of HIE, whether it is the basal ganglia pattern, watershed pattern, or the diffuse cortical pattern, which the pattern will determine the likelihood of developing epilepsy in the future. So yes, for MRI, I know that I faced the struggle when I came back, because a lot of the neonatal, the NICU, they don't have the capability, one, for electrode compatible EEG, for example. It does not exist, or like a transportation between the MRI suite and then the baby is unstable. So getting MRI is challenging. So I understand that, but at least a CT or ultrasound, whatever, anything to look at the brain.
Okay. Before we start phenobarb, do we have to take a consent from parents, or we can just consider it part of our routine care so we don't have to take the consent?
I would say institutional dependent. I have never come across in my life, either in Saudi or outside, that I need to take a consent for any like acute medication that I'm giving to the patient.
Okay, this question from Dr. Azhar. What can cause clonic seizures with MRI finding showed bilateral symmetrical frontal and occipital infarction like picture? No hypoxia, no hypoglycemia, normal lab, good baby, a general condition.
Okay, I'm very hesitant to give answer for a specific case because the answer is always not inconclusive. As we said, there is a general rule. Clonic is most likely to be associated with a structural, especially stroke. It doesn't mean that that clonic seizure mean only stroke and nothing else. No, still HIE, still intracerebral hemorrhage can cause a clonic seizure. So the underlying structure would not, if there is a clear HIE presented with a clonic seizure, I wouldn't say that, oh, this is alarming, that it is probably something else. I don't know what we are getting at in terms of the question.
Okay. What is the role of lorazepam as acute management?
Excellent question. Okay, so this is an institution-dependent pathway. For example, I'll tell you my experience at Sick Kids Hospital. We used to start immediately with lorazepam. It's easy access, it's available bedside. They don't need to go and get it from the pharmacy. So once you confirm the seizure, you immediately start with lorazepam. Some other institution, if there is still doubt and they need to get the medication of pharmacy, they go immediately to phenobarb. So if it is, it depends on an institution. It is in the algorithm, and if you have it readily available, start with lorazepam. Yes.
Okay, and here this question from Dr. Anfal. If we have a baby with a seizure on phenobarb and other anti-epileptic medication, then he developed a seizure again, can we give a loading dose of phenobarb even if the level of phenobarb is normal or high? Should we try other medication, or we can just load the baby again while we have normal or high level?
Okay. So again, this depends on the pathway and depends when the seizure happened. If we are talking about now, like frequent seizure, we just load the patient is still ongoing seizure. Yes, you can give the total phenobarb load that is agreed upon in the acute setting within like 24 hours is 40 milligram per kilo. 40 milligram per kilo. This is the total dose, regardless of the level. There is no need to monitor the level immediately. But if, for example, you reach that, you already gave that amount of phenobarb, you definitely should go to second line. You will not keep repeating phenobarb. You should look into your other option, especially lorazepam or even phenytoin in the acute setting, not as maintenance. Okay. Just for phenytoin, it's good that I remember to talk about phenytoin. If any of the fellow works in a cardiac center, be careful about phenytoin with cardiac babies because of arrhythmia. That's the only reason sometimes in cardiac babies we don't prefer phenytoin and we would go for levetiracetam.
Okay, and here another question about discontinuation. Do we have to discontinue anti-epileptic medication based on the clinical or electrographic free seizure?
No, it's both. So you stop the medication. Okay, again, I hope my message was clear that you continue the continuous EEG for 24 hours until after you wean if the baby is on infusion and until the resolution of any seizure, either clinical or electrographic. So you need 24 hours at least of seizure freedom with no medication, clinical and EEG. Once you establish that and the baby is seizure-free for the next time until upon discharge, stop the medication before you discharge the patient home.
Okay. If we reach to the weaning stage and patient on phenobarb and Keppra, do we start weaning Keppra or phenobarb first?
Okay, I hope by that time you involve your pediatric neurologist colleague, because everything has to be stepwise approach. There is no right or wrong, and there is no standard which one you need to wean first. Technically, because phenobarb has a longer half-life, So you would keep it and go first with Keppra. And again, we always go gradual, okay, by week. Sometimes we go 25, reduce the dose by 25% or 10% until discontinuation. But again, usually I would suggest that you involve the pediatric neurologist for the weaning plan.
Okay, is there any rule of clonazepam in neonate?
Not that I'm aware of.
Okay, the question regarding weaning, already we have the answer. And if we decided to start Keppra, what is the loading dose, or start low dose and increase it gradually?
No, so always the idea of a load is not, the idea of a load is you pick the biggest load, the biggest dose, and that's it. This is the idea of load. So it's there is that's why there is variability in the protocols depend on the institution. Some institutions are comfortable up to 60 milligrams per kilo for neonate.
Okay.
As a single loading dose.
Is there any rule for surgical treatment for seizure from point of view?
Oh, this is a vague question, or for neonate per se, or like epilepsy surgery? I don't get that.
Most likely for neonate.
Okay, so there is nothing called epilepsy surgery for neonate. Does not exist. Okay, for example, the only reason. Okay, so this is a big topic. So epilepsy surgery, there is too many different types. But in short, even if neonate had a stroke, he will not be candidate for a surgery in neonatal period. The seizure will happen, needs a lot of other pathway of epilepsy surgery workup if this is the only reason for their epilepsy. Okay, so but for example, a neonate who was born with a brain tumor, okay, that needs to, and it was causing seizure, but the tumor need to be resected, so the tumor will be resected. It is not epilepsy surgery. It just the tumor has to be removed. If this makes sense, okay.
Okay.
Like for example, HIE, ICH, all these things, it will be directed based on the treatment needed to their specific case by neurosurgery, not necessarily because of the seizure per se. We talk about epilepsy surgery in probably older, not in the neonatal period.
Okay, and here we have another question regarding phenobarb loading dose, if we can repeat it after few days from the first load. This is a repeated question, but I think it wasn't clear. The answer wasn't clear, so we can just...
yes, it can be repeated.
But I think we have to do like a level after the 5th dose. So if the level is high or normal, I think we have to think about other anti-epileptic medication. Is that right, Dr. Daniah?
It depends on if the baby is in a status epilepticus, it means that even that level of the phenobarb was not sufficient to stop the seizure. So your treatment algorithm for seizure pathway should be like straightforward, okay? You might think about, okay, I'll give him, ideally you should give, the actual dose is 20, but for example, you might say, no, I'll just only give 10 milligrams per kilo. Because of the risk of, if you want to, because we know in neonate, the phenobarb is more potent than if you start Keppra, yes, you can start Keppra. This is the area of gray. There is no clear, if you want to try Keppra, yes, try Keppra. But if the level of high, and again, high or therapeutic, I don't mean like they are sky high and they are not waking up and totally encephalopathic. You will probably take it case by case and decide. But the level, usually I say that the level is, the upper limit is 30 and the level is 35. Should we give? I would not hesitate. I will give.
Should we treat any seizure activity even if it is focal and the baby was stable vitally? This is, I think, in case if we don't have EEG.
Okay, if it is the first seizure, yes, treat immediately, don't wait. Bottom line, yes. If you have if this is clonic or tonic and it is very strongly, you feel that this is a seizure and it is the first time, no doubt, treat.
What is the self-limited neonatal seizures?
Okay, so these are epilepsy syndrome. There is many of them. We make this diagnosis in retrospect. Let's say that this neonate was a well baby who was actually even discharged home and then came back day 3 of life with seizures, but he's still like the seizure well tolerated, like well responded to anti-seizure medication. And then after a year, the baby had no further seizure, okay? Then we would probably think that this could be. And by that time, hopefully we have, because it is usually genetic diagnosis, if we have a genetic diagnosis for certain channelopathy, KCNQ2, that is known to cause self-limited neonatal epilepsy, then we will feel comfortable to discontinue the medication, especially that there is a family history to support that this runs in the family. There is either a brother or a cousin who had the same thing and resolved in the neonatal period. So as I said, it's a retrospect diagnosis and genetic diagnosis as well.
And here we have a comment from Dr. Muna Hunaini, and I totally agree with her. Thank you. It was very informative and up to date. The articles you cited are very helpful, and it's an amazing talk.
Thank you so much. Thank you.
Thank you, Dr. Dania, for your comprehensive talk, and to the audience for participating actively in this session.
شكرا جزيلا. شكرا دكتورة دانيا لتلبية الدعوة. شكرا دكتورة نجلة على إدارة الجلسة. شكرا جزيلا للحضور الكريم. نلتقي في محاضرات قادمة إن شاء الله تعالى. شكرا جزيلا جميعا. Thank you.